NTEP perspective of abdominal TB. As far as NTEP perspective is concerned, it is almost same for all the extrapulmonary tuberculosis, except for say for neurological, there is some difference. There is a role for steroid, and pericardial there is a role for steroid, and regarding duration of treatment also there is some difference for skeletal and neurological. Otherwise, it's almost same for all tuberculosis. So most of the part is discussed by regarding abdominal tuberculosis discussed by Dr. Premalda. So I will try to finish my talk as quickly as possible. So tuberculosis can involve any organ inside the abdominal cavity. The most common forms are peritoneal and GI tuberculosis. So the principles in NTEP is to promote early diagnosis in any form of tuberculosis, so that we can avoid sequelae formation, and we can avoid spread of the disease also to the adjoining structures. And it also recommends microbiological diagnosis. In order to have a microbiological diagnosis in abdominal tuberculosis, we should have at least either tissue or ascitic fluid, and we should always assess the patient regarding the risk of drug resistance. If the patient had a previous treatment, or if it is a retreatment case or a relapse case, or if there is exposure to a DRTB patient, then we should extensively assess the patient for drug resistance before starting treatment. For this purpose also, we should have a microbiological diagnosis, and as far as possible avoid unnecessary invasive and sophisticated investigations, so that we can have a diagnosis in the periphery itself. In case of abdominal tuberculosis, in peritoneal tuberculosis it may be possible. Otherwise, in other cases, usually the help of a gastroenterologist is needed. And all the patients with tuberculosis should be screened for retro, and all the patients with tuberculosis should be screened for pulmonary tuberculosis, because it is as far as program is concerned, it is more risky to cause spread of the infection to others, and we should ensure effective treatment, and we should follow up the patient regularly for to ensure compliance. The main problem in the we are facing in the abdominal tuberculosis is the definite guidelines for the diagnosis. It's a real challenge in all forms of extrapulmonary tuberculosis, and absence of facility and expertise in the periphery for early diagnosis. So all primary care physicians should be aware of the symptoms and signs in abdominal tuberculosis, so that they can be referred to a specialist as early as possible, because diagnosis of GI tuberculosis is not possible in the periphery. And regarding the uncertainty about treatment duration, because in case of abdominal tuberculosis, about more than 80% of cases diagnosed based on clinical features, imaging features, and probably histopathology. So we don't unlike in pulmonary tuberculosis, the treatment follow-up is very difficult, and so also when to say the treatment has failed is also very difficult. The main problems for high prevalence and reason for sequelae is a delay in diagnosis. So we should have a high index of suspicion and try to diagnose the case as early as possible, and should avoid inadequate treatment. The inadequate treatment may cause high rates of recurrent TB, and which may also lead to drug resistance. Today also there was one reference to from our casualty for takeover. It is a case of sputum positive pulmonary tuberculosis, there was empyema, and on taking CT there is evidence of abdominal tuberculosis. So still in Kerala there is a delay in diagnosis and treatment. In outside Kerala the condition is very bad, but in Kerala also there are some problems. Another problem that we are facing is in migrant workers. There are so many cases of disseminated tuberculosis in migrant workers. Then another problem is high prevalence of diabetes mellitus in Kerala. Then many patients with immunosuppression due to retro and many other reasons. Many patients with organ transplantation. Then immunosuppressants for connective tissue disorders, ILDs, etc. Then another is malnutrition. So this is the data from our institute, that is Government Medical College, Kozhikode, from January 2020 to May 2021. There were a total 1,007 cases of tuberculosis. This is excluding HIV TB combination. Out of this 1,007, there were 342 pulmonary tuberculosis. Out of this 342, 230, that is more than 2/3, were having a microbiological diagnosis. Whereas out of 665 extrapulmonary tuberculosis, only 48 had microbiological diagnosis. So there is around 7%. This may be because in last 1 year, one and a half years, the microbiology department is engaged mainly in COVID screening at all. And we don't have a gene expert at our institute now. That machine is used for COVID purpose. And coming to extrapulmonary tuberculosis, out of 665, we had 185 pleural. That may be because in our institute so many pleural efficients are coming. And 107 abdominal tuberculosis was there. That is about 15%. In the index TB guidelines, the prevalence is about 3%. This is much higher because it is from one institute alone. It's a tertiary care center. And coming to HIV TB, out of 48 cases, 31, that is about 2/3, was extrapulmonary. So this is already discussed. As in case of any form of tuberculosis, diagnosis can be either presumptive, can be either a presumptive case or a bacteriological confirmed case or clinically diagnosed case is already discussed. So also labs can be presumptive, bacteriological confirmed or clinically diagnosed. These symptoms, as I've already told, all primary care physicians should be aware of these symptoms. This is discussed in detail by Professor Premalata, so I don't go into that. Coming to peritoneal tuberculosis, if there is features of exudate in the form of protein more than 3 g/% and SAC less than 1.1, and if the ADA is more than 39, then it's most probably tuberculosis. And PCR is not recommended in as per guidelines. Not only Indian guidelines, even if you search for US, it's not recommended. In case of presumptive GI tuberculosis, endoscopy is a must and should get a tissue for histopathology and for culture. In case of GI tuberculosis, PCR is not recommended, so because the result is highly variable. Regarding specimen collection, any form of tissue should be sent for histopathology in formalin, and another specimen should be sent as such. If you can, if the laboratory is nearby, if there is a risk of drying, should send it in saline without adding any preservative. The ideal medium is Kirchner's liquid medium, but that may not be available, and our temperature should be between 4 and 15 centigrade. But you can send the specimen in saline for culture and for CBNet. Even though CBNet is not recommended, I don't think there is no harm in doing it, because some published articles show a yield of 60-70%. Risk factors for peritoneal tuberculosis are cirrhosis, then peritoneal dialysis, underlying malignancy, and all. In all these cases, there can be ascites. So the diagnosis is very difficult. And in case of peritoneal dialysis, risk of tuberculosis is highest in first year, and presentation may be similar to that of bacterial peritonitis. And instead of lymphocytic, may be neutrophilic. So it's very difficult to diagnose. And in case of patients with CLD, you may not get typical features of exudate. SAG may be more than 1.1 gram per deciliter. And in general population, AD of more than 39 has a sensitivity of more than 90% and specificity of more than 90%. But in case of patients with cirrhosis, the sensitivity of AD is low. And if you reduce the cutoff point to 39 or low, then the sensitivity may be better. And mycobacterial culture for fluid, the yield is around 20%. But if you send 1 liter fluid and centrifuge the sample and do the culture, then the sensitivity may be as high as 80%. In case of GI tuberculosis, should do a colonoscopy and ileoscopy and should, or even enteroscopy, and should get a biopsy. PCR is not recommended. And the other things Madam has described. So this is from a review article. You can see that the sensitivity of FB smear varies from 2.7 to 37%, but average sensitivity is around 10%. And in case of FB culture, it varies from 2 to 70%, but the average, I think it is around 20% only. This is the main deity of GI tuberculosis is Crohn's disease. This shows the various features in Crohn's disease and intestinal tuberculosis. If you look at the various features, longitudinal ulcers, even though it is more common in Crohn's disease, you can get it in GI tuberculosis also. So also transverse ulcers is more common in tuberculosis, but it is present in Crohn's disease. After ulcers, you can get it in both, even though it is more in Crohn's disease. And patulous wall also, you can get it in both. So no lesion, no endoscopic finding is diagnostic of tuberculosis. And coming to histopathological features, if there are 2 or 3 features that can differentiate. If there are more than 10 granular mass per biopsy site, then it is not seen in Crohn's disease. So seen only in tuberculosis. So also caseous necrosis is not seen in Crohn's disease. It's seen only in tuberculosis. Large granulomas, even though it is more common, more than 400 microgram, even though it is more common in tuberculosis, you may get it in Crohn's disease also. So also submucosal granuloma, which is more common in tuberculosis, and mucosal granuloma is more common with Crohn's disease. So these are there are only 2 differentiating points which is not seen in Crohn's disease according to this review article. So if there is a diagnostic confusion between intestinal tuberculosis and Crohn's disease, better to start the patient on anti-tuberculosis treatment. Reassess after 2 to 3 months with the colonoscopy, and reassess. If there is no improvement at all, then we may think in terms of Crohn's disease. If there is improvement, we can continue with the anti-tuberculosis treatment. Coming to treatment, it is the standard first-line treatment. That is 2 months of treatment with the HRE set, followed by 4 months of HRE, FDCs, depending upon the weight band and the comorbidities. There is some renal problem, you have to adjust accordingly. So also there is hepatic disease, you have to adjust. Even though 6 months treatment is recommended, the clinician may extend it if it needed. It's better to reassess the patient at 3 months and 6 months. If you reassess before 3 months, there is a chance of confusion because of paradoxical reactions and errors in case of cases. Treatment outcome. If the patient has completed 6 months of treatment, then it is the patient has completed treatment. And if there is a symptomatic improvement, you can say it is successfully treated. But even if you have successfully treated, in some patients, there may be persistence of symptoms due to sequelae. So you should follow up the patients regularly in order to assess the patient whether he require any more treatment or not. And treatment failure also, it can be presumptive, bacteriological, clinically diagnosed, but it is difficult to assess because the bacterial diagnosis is available only in less than 20% of cases. Thank you.